I welcome you all to this CGR. In this, we are trying to present the audit of the oral cancer management from NCI. Actually, this data is mainly from NCI and how we have been improving our practice during the years. And since this treatment requires multidisciplinary management, so we have also included other departments, including onco-anesthesia, pathology, radiation oncology, and medical oncology in this presentation. So we'll start from our department. So we can
Thank you, sir. Uh, first of all, I would like to thank my teachers for giving me opportunity. Oral cavity remains one of the most common cancers encountered in our day-to-day practice. This data I have taken from a Lancet article. It shows the prevalence of tobacco users who are more than 15 years of age across the globe. The data is taken over 204 countries, and it shows that in India has the highest prevalence of tobacco users who are more than 15 years old. This article is published in e-cancer statistics, and it highlights the burden of head neck cancers in India. In male population, the age standardized incidence rate is around 26 per 100,000 population, and it is highest in Northeast region, followed by Northern India. In Northern India, mouth followed by tongue remain the most common sites of head neck cancers. This is a sheer number which compares the burden shared by India, and it compared with other developing nations like Brazil, Sri Lanka, and also with Australia and USA. Whereas in India, a standardized incidence rate for male head neck cancer is almost 25%, whereas in US and UK it is 4.3%. This is again a comparison, country-wise comparison and a site-wise comparison. For country like India, for mouth cancer, incidence rate is almost 8.7 per 100,000 population in male persons, and followed by tongue sites. At NCI, over the years, our OPD, IPDs, and OTs has increased. In 2020, we almost see 1,000 patients, and last year we have seen 9 times that of our initial start. In 2020, the IPD admissions were around 140, and in the last year till December 23, we have almost 640 IPD admissions in Department of ENT Oncology. The major surgical procedures which are carried out over the years accounts to around 1200 plus. And in last year alone, we have done almost 400 plus major procedures. Out of the 1213 head neck cancer patients operated at NCI, around 60% belong to oral cavity cancers. And out of this, around 63 are buccoalveolar complex areas, and another 36% belongs to tongue. This is a year-wise distribution of various operated cases. For buccoalveolar complex, we have operated almost 187 patients last year, and for tongue and floor of mouth subside, we have operated around 86. The district tongue remains the second most cancer we encountered in our practice, and majority of our population, they belong to advanced cancer. They are T3 and T4, accounting almost 65% of our patients, which we see in our OPD. And below table shows the type of surgeries we perform for such tongue cancers. Over the years, we have shifted more towards compartment glossectomies. Our total partial glossectomies are 63, our total compartment are 105. We also have done some 73 subtotal glossectomies and near total glossectomies around 26. Historically, the most common surgical approach to tongue cancer is a wide resection with free clinical margins. However, over the years, the stage and the outcome of tongue cancer has not changed much. So, Calabrese proposed a new method of compartment resection where it hypothesized that the tongue tumors, they almost behave like musculoskeletal compartments. And if we take out as a whole compartment, then maybe we are able to achieve much more better surgical resections. He published his data of around 143 compartment surgeries in oral oncology in 2011, and it demonstrated a clear improvement in overall survival of around 27%. In our institute, we have also performed compartment glossectomies. We have performed around 54 procedures, and these table shows the clinical and the functional outcomes of the patient. Around 50 out of the 54 patients, only one patient we failed to decannulate, and basically this patient has contracted COVID infection post surgery, and it's come to death because of COVID related problems. In total cohort of 84 patients, one patient has to be converted into gastrostomy tube after 4 weeks of NG feeding. We have also seen what are the swelling outcomes for this subset of population. At around 33rd month, we have 48 patients which we were able to follow in compartment surgery group, and almost 43 patients, they have normal to voluntary swelling functions. The speech outcomes we calculated as an intelligibility grade and intelligibility score. Third month of follow-up, around 48 patients out of 54 patients, they have speech intelligent speech they were able to achieve. However, we have obtained the functional outcome for compartment glossectomy on speech and swelling. The long-term oncological outcome, we are still waiting. We have to analyze our data. We have to wait for some time. Advanced tongue cancer remains another cohort of a patient, which account almost 60% of our cohort. And in this, we have performed around 73 subtotal and 26 near total glossectomy over the period of 4 years. The management of local advanced tongue cancer poses a significant challenge in terms of achieving meaningful functional outcomes. Here we publish our prospective data of 39 patients in which we used pectoralis major myocutaneous flap for reconstruction of the tongue. Around 39 patients were prospectively enrolled, and majority of our patients were young patients, and around 88% of them are clinically T4A disease. And the most common surgery we performed in this cohort was subtotal glossectomy. And in almost 90%, 95% of the patient, we were able to preserve the mandible. In this cohort, we were able to decannulate almost all patients within 6 months of follow-up. And 3 patients had their nasogastric tube for more than 2 months. However, at the 6 months follow-up, almost all patients were able to take oral feeds. Our study demonstrated a gradual improvement in swelling dysfunction, but significant abnormalities persisted in social and functional well-being areas. However, our work contributes fresh evidence to the existing body of literature, which has substantial impact on the surgical care of advanced tongue cancers, especially in resource-constrained nations. This was one of the few studies where the PMF has been used for the reconstruction of the tongue, and this study was novel in that aspect. Bucco-alveolar complex is the most common cancer we operate, and almost 68% of our cohort are clinically advanced disease. We have performed full thickness wide local excision in almost 168 patients and segmental mandibulectomy in 144 patients. As the boundary of resection are expanded, the process of reconstruction becomes increasingly difficult. Over the years, we have to take bigger flaps, and PMMC remains the most common flap which we have done over the year. Our last year, only around 150 reconstructions are done with a PMMC flap. And we publish our experience with the pectoralis major myocutaneous flap, which is a workhorse flap in head neck reconstruction. In this series of 196 patients, Overall, flap compromise was noted in 17.6%, and the full failures were noted in only 3 patients. In our cohort, bipedal PMMC and the large surface area were factors favoring a better outcome. And it verifies the literature finding that the PMF in female patients, they have much more greater chances of complications. In our cohort, they have odds ratio of almost 10. Older series have identified bipedal PMF as having a higher incidence of flap complications. However, in our series, we observed better result in bipedal subset. And this especially is attributed to our surgical technique, where we try to identify and preserve the lateral pedicles so that the vascularity doesn't get compromised. Supraauricular artery based island flap is another flap which commonly used for our low volume buccal mucosa defects. Conventionally, the flap is harvested based along the supraclavicular vessels using anatomical landmarks. But over the years, we've seen that CT angiography is a better guide for telling the reliable blood supply. And in our cohort, there was a complete flap success if we have identified the vessels preoperatively as compared to the anatomical triangle-based method. So for this supraclavicular artery-based flap, we recommend the CT angio so that the vessel should be identified preoperatively for the optimum flap outcomes. Another important aspect of our resections are the neck dissections. Contralateral neck dissections remains treatment dilemma, where for the well lateralized oral cavity cancers, whether it should be done or not. We retrospectively analyze our data, and 189 patients were involved in that. We included patient in which the primary tumor was located within 1 centimeter, depth was more than 10 mm, and there was clinical involvement of skin. In our cohort, stage 4B disease, extranodal extension were found to be significant predictors of contralateral disease. We have changed our practice in view of this data. However, the long-term survival data is still pending. Along the course of our practice, we have also identified some upstream neck node levels, and one of them is a lingual node level. This is an article which was published in scientific reports, where they have shown that the lingual node metastasis, if present, it almost it is a poor predictor of overall survival, and it almost decreases the survival by 39%. In our cohort, we have analyzed around 84 patients, and in our cohort, the incidence of lingual node metastasis were around 6%, which was similar to this study. And another new finding which encountered is that the conventional neck dissection fails to clear this nodal level. So we change our surgical practice in view of our findings, and compartment dissections are favored over wide local excision to address these upstream nodal levels. Another nodal level which was not conventionally described in literature for neck dissection is the perimarginal nodes. Perimarginal nodes are the group of nodes which are located on the marginal mandibular nerve. We analyzed our data in 112 patients. They were present in 85 cases, and they were positive in around 15% of the population. They are frequent site of oral and lip cancer, and these levels are not uniquely dissected in neck dissection. Our study shows they should be addressed for adequate neck clearance in oral cavity cancers. So over the years, we have changed our practices in terms of management of tongue cancers. We have moved from wide local excisions to compartment glossectomy so that better oncological results can be achieved. And at the same time, we have not compromised on the functional outcomes. For the advanced tongue and floor mouth cancers, for disease which were earlier associated with poor swelling outcomes, we have shown that the PMMC is a reasonable flap and can be used in large tongue defects. For large buccal cancer defect, we have shown that bipedal PMMC is a good reliable flap and can be used over again. SCIFE, we have moved from anatomical identification of vessels to the CT angiography vessels. And the two nodal levels we have started in our practice, routinely addressing in our practice, are the lingual nodes and the perimarginal nodes. Contralateral neck node, there was a lack of evidence. We have generated some evidence, and we know that it can be performed in clinically T4P diseases. Thank you.
Very good afternoon. I am Dr. Satyaki, Senior Resident in the Department of Onco Anesthesia. And on behalf of my department, I would like to introduce you to the perioperative challenges and concerns that we face from the perspective of the anesthesiologists, particularly in relation to head and neck cancers. So this table summarizes in brief total of the number of cases, head and neck oncological cases that have been undertaken under general anesthesia at NCI over the years from 2020 to 2023. And as previously identified also, we see a steady increase in the number of cases starting from a modest number of around 150 cases in 2020 to approximately 650 cases in the year 2023. So that gives us around a cohort of around 1,800 patients of head and neck cancers. Of these, we would like to believe that we have had a pretty successful perioperative outcome in terms of morbidity and mortality. The perioperative major morbidities were only 0.015%, which is 27 of the total number of cases. And in the year 2020, we had 6 major morbidities, 3 of which were accounted for by persistent hypocalcemia. All the patients were managed conservatively and were subsequently discharged home after calcium supplementation in an oral form. And there were 3 cases of delayed weaning. So what we do currently is we follow overnight sedation protocol for most of the head and neck cancer surgeries, and we wean the patients off the ventilator early next morning. So the 3 patients, they had around 12 to 14 hours of extra pulmonary ventilator dependence, mostly due to preoperative comorbidities that led to a delayed weaning. In the year 2021, we managed again 356 cases, of which there were 4 cases of hypocalcemia, 1 case of delayed weaning, and we had 5 incidences of major cardiac comorbidities, 3 cases of perioperative pulmonary embolism, which were diagnosed on the postoperative day 3 and 4 when the patient presented with shortness of breath. CT angiographic evidence was registered. All the patients of pulmonary embolism were managed conservatively in liaison with the cardiology department of AIIMS, and since we do not have a full-fledged cardiology backup at NCI as of now. And 1 case of perioperative MI occurred in a 58-year-old male patient who was previously hypertensive, which was also with ST changes and post-operative cardiac dysfunction with regional motion abnormality, again managed conservatively. Similarly, we had in 2022, we had a relatively less number of morbidity, 1 case of perioperative MI and another case of hypocalcemia. Finally, in 2023, apart from the routine comorbidities, routine morbidities that we faced postoperatively, we had 3 interesting cases that we would like to discuss. One was a case of cerebral venous thrombosis in a patient where the ipsilateral IJV had to be ligated and sacrificed. The patient had a persistent pain along with headache and photophobia. Initially, interventional pain procedures, including a trigeminal nerve block, was attempted. Since the definitive pathology was not identified at that point of time, till that point of time, on further investigation, the patient was found to have cavernous sinus thrombosis, along with the involvement of the sagittal sinus. They were conservatively managed again with acetazolamide and ICP reducing measures like mannitol, and the patient was successfully discharged home. Another patient was a young male patient with idiopathic thrombocytopenic purpura pre-existingly, who was operated under platelet coverage. He underwent a procedure of buccal mucosa composite resection, buccal mucosa composite resection, and on POD5 he developed hematoma with a flaring up of the symptoms of ITP. He was also managed and finally discharged on after a megakaryocyte stimulating factor, romuplastin. And other than that, we also managed 2 cases of perioperative MI and 1 case of pulmonary embolism. So regarding this, what we would like to highlight are the takeaway points that we as a head and neck anesthesiologist would face, the challenges that we face and how our department holistically approaches those problems. The first problem that we face is the problem of difficult airway. The majority of the patients with buccal mucosal carcinomas have minimal to nil mouth opening, achieving a definitive airway for a surgery without going for a tracheostomy that or a tracheal tube placement that interferes with the surgical field. We usually employ awake or flexible video bronchoscopic guided intubations. For achieving that feat with minimal patient discomfort, we use various methods of airway topicalization and a wide variety of airway blocks, including transtracheal blocks and superior laryngeal nerve blocks. Also, to reduce the incidences of peri-intubation desaturations, we have started using peri-intubation high-frequency nasal oxygenation support that has led to less frequencies of desaturations and better intubation outcomes. Finally, certain cases do require intraoperative nerve monitoring, where we do the maintenance of anesthesia with TIVA for evoked potentials, and we ensure a proper depth of anesthesia with the neuromuscular blockade monitoring and entropy or BIS monitoring. The other concerns that we have, that this determines a good outcome or good perioperative outcome are the previous comorbidities, which need to be optimized at the time of taking the patient up for surgery. Also, most of these head and neck cancer patients have poor nutritional status to start with. As we have already seen, the feeding procedures post-ready head and neck RTs, like gastrostomies, percutaneous gastrostomies, and pharyngiostomies, we provide a backup for those, anesthetic backup for those procedures as well. We also admit some patients and provide IV iron therapy in cases they are anemic. Also, since weaning and extubation is difficult, particularly in oral cases, we have our ICU caters to the overnight sedation and mechanical ventilation, and we have staged weaning protocols. In cases of difficult airways, we usually employ a airway exchange catheter and under reintubation precautionary measures for reintubation. We usually extubate these patients, and we have not had any untoward incidents in the recent past. And also, post-operatively, we employ respiratory therapies, both in the form of nebulization as well as chest physiotherapies. For patients during the durations of their less ambulation or sedation, we use chemical as well as mechanical DVT thromboprophylaxis. And the final thing that we want to mention is that pain is a debilitating concern that most of these head and neck cancer patients have. And in the form of a comprehensive pain clinic that covers both intraoperative and postoperative pain, along with the acute pain services that we run, we ensure that patients adequately have a NRS or a numerical rating scale pain score of less than 3. We follow them up till discharge and ensure that even patients who have been discharged with opioids are weaned off as soon as possible. And finally, we also employ nerve blocks and radiofrequency ablations. Thank you so much.
Good evening. I'm Dr. Priya Jaikumar, resident in Department of Pathology, and I'll be talking about the histopathological prognostication of oral cancer. Despite the advances in surgical management of oral cancer, there remain disparities in the outcomes within oral squamous cell carcinoma. Until 2017, minimum required information was included in reports. The diagnosis, grade of SCC, extent of invasion into bone and skin, margins, whether they were free or involved, shave margins were taken, distance was not measured, and number of lymph nodes showing metastasis was included in the reports. We have come a long way since then. Now our reports are much more detailed, providing information on several parameters that are of prognostic significance and are required for staging. We include depth of invasion, burst and predominant patterns of invasion, lymphocytic host response, perineural and lymphovascular invasion, tumor budding radial margins, free flows, which is up to 5 mm, or involved, with distance in mm included. Extent of invasion into bone, skin, masticator space are included in the reports. Lymph node metastasis, the size of the metastasis, extranodal extension, and the size of the extranodal extension is also included. These changes did not happen overnight. The first step that we took was improvement in grossing techniques. Detailed gross descriptions are written for both smaller wide excisions as well as complex composite biter sections. Well-oriented sections for accurate measurement of depth of invasion is taken. Inking of margins is done. Margins are now sampled radially and not as shapes to measure the distance from the tumor. And also continuous training of grossing JRs is done by the head and neck pathology faculty. The next area of growing interest in development is the tumor-host interface. It is the deepest portion of the tumor with the surrounding stroma. Here, the tumor cells interact with the host immune cells, modifying biological properties. Invasion and metastasis, the hallmarks of carcinogenesis, are observed here, where presumably the most aggressive cells reside. This has emerged as an important area of research, interest in solid cancers, and we've decided to explore it as well. Brandby and Gensler proposed a simple histological risk score for prediction of disease-free and overall survival. It's based on 3 parameters: worst pattern of tumor infiltration, lymphocytic host response, and perineural invasion. Even in the high-risk group, free margins did not protect against locoregional recurrence. Radiotherapy was beneficial even in early-stage diseases, and this was prior to AJCC 8th stage modification. This is the histological risk score based on 3 parameters. The CAP protocol recommends documentation of worst pattern of invasion 5, but not other patterns or parameters. We assessed the score in 178 cases of oral squamous cell carcinoma. These are the patterns: Cushing border, pattern 1, pattern 2, finger-like, pattern 3, nests of 15 cells or more, pattern 4, less than 15 cells nests, and pattern 5, which is the tumor satellite 1 mm from the main tumor or the tumor island. Predominantly, pattern 4 was seen more. A band of lymphocytes, lymphocytic distribution, or patchy or sparse lymphocytes in the tumor host interface. Small perineural invasion in small nerves and perineural invasion in large nerves. Our experience was that the scoring was valid on AGCC 8 staged oral cancer, significant predictor of nodal metastasis, disease-free and overall survival in both early and late stage. It is a prognostic impact of BG score was equivalent to as well as additional to the impact of TNM staging, and each of these 3 parameters had independently impacted the survival outcomes. We then proceeded to study the subset of tumor-infiltrating lymphocytes at the tumor host interface in 50 resected cases of oral squamous cell carcinoma. The distribution of immune cells was such that CD3 positive T cells were accounting for majority, and it included both CD8 plus T cells, FOXP3 cells, CD4 T cells, and CD20 were fewer in number. In a graph in which tumor-infiltrating lymphocytes with 2-year overall and disease-free survival, we found that CD8 and FOXP3 had prognostic significance in the survival outcomes, where high CD8 and low FOXP3 had better survival outcomes with longer survival rates. And we then clinically assessed the cutoff values for CD8, clinically relevant cutoff values for CD8 tumor-infiltrating lymphocytes FOXP3 and CD8 FOXP3 ratio. On comparison with histological tumor host interface and staging parameters, low CD8 and high FOXP3 and low CD8 FOXP3 ratio were associated with worsening categories of tumor host interface parameters: worst pattern of invasion, perineural invasion, BG histological risk score, indicating that tumor microenvironment does modify the tumor properties. Low CD8 FOXP3 ratio is significantly associated with nodal metastasis. Thus, some tumor-infiltrating lymphocyte subsets were more clinically relevant than others, and quantification of key tumor-infiltrating subsets may aid in better prognostication of oral squamous cell carcinoma. We talk about tumor budding, which is another parameter in the tumor interface. Tumor budding is nests of 5 or less cells seen at the invasive front. These are non-apoptotic aggressive clusters of cells at the invasive front. They have characteristics of cancer stem cells associated with loss of cell adhesion, expression of epithelial mesenchymal transition markers, and are implicated in invasion and metastasis. This was first described in colorectal carcinoma, and it has also been studied in other systems. High tumor budding is identified as a predictor of occult nodal metastasis. The most common cause of relapse in early stage oral squamous cell carcinoma of recurrence, distant metastasis, and shorter survival. There is no consensus on method for scoring, which prompted us to evaluate different scoring systems. So these are the scoring systems that we evaluated based on 3-tier and 2-tier systems, and we of low, intermediate, and high budding, and we compare the clinical pathological features and survival outcome in a 3-tier and 2-tier system. We found that low tumor budding had better survival outcome of longer duration, and high had lower survival outcome with shorter duration. Also, there was a significant difference between intermediate and high tumor budding, which said that intermediate cannot be clubbed with high. It has to be evaluated on a 3-tier scoring system. And on multivariate analysis, tumor budding was an independent predictor of mortality and lymph node metastasis. All these new parameters are now included in our reports, which have led to improved staging, are routinely used for prognostication of patients following surgery. Some BG score parameters like peridural invasion are definite indicators for adjuvant chemoradiation. Others like burst pattern of 5, which is indicative of extremely aggressive behavior, may serve as soft indicators for deciding adjuvant therapy. Newer parameters like tumor budding do not have global consensus recommendations thus far, but our data supports their inclusion with appropriate scoring in all our reports. Notably, all of this work was initiated at the suggestion of our surgeons, who are always looking for novel parameters to better understand the marked heterogeneity in oral squamous cell carcinoma patient outcomes. Thank you.
A very good evening to everyone present here. I am Dr. Agrija Ghosh from the Department of Radiation Oncology, NCI AIIMS, and I would like to talk about radiation therapy in oral cavity cancers. So basically, radiation is of two types. The external beam radiotherapy, where the radiation X-ray is delivered from outside into the patient's body, and brachytherapy, where via these catheters, we are sending radiation from inside the tumor. Radiation forms a very, very important pillar in the management of oral cavity cancers in the adjuvant setting. For the intermediate risk group, adjuvant RT is indicated, and if there are high risk features like positive margins or extranodal extension, adjuvant chemoradiation is to be considered. Not only that, even in the radical setting, for early stage oral cavity cancers, radical radiotherapy with a brachytherapy boost provides excellent outcomes. And for unresectable, locally advanced oral cavity cancers, radical chemoradiation can also be offered to the patient. Starting with the external beam radiotherapy, what used to be the standard was a historical 2D technique via these fields using a telecobalt machine. A dose of 60 to 66 gray in 30 to 33 fractions was delivered to this whole area. So the tumor, not only the tumor, the surrounding normal tissue also received that high amount of dose, which actually led to a lot of toxicity. At NCI, we have state-of-the-art machines, two fully functional variant true beam linacs, treating 160 patients per day and functioning 14 hours per day. Coming to the target volume delineation, what do we radiate in a oral cavity cancer? This is the post-operative bed that has to be taken into our target volume, and the nodal levels at risk are also included. We try to spare one side of the neck by doing unilateral radiation in well lateralized N0 neck tumors of the buccal mucosa or well lateralized oral cavity cancers. What is even more important for us is to ensure that the target gets that tumoricidal dose, but the organs at risk, that is the nearby organs important for all the functions of swallowing and everything, they are preserved. So on every slice of the CT scan that we acquire, we have to delineate these organs. Here you can see the lips, the tongue, the base of the tongue, the supraglottic larynx, the superior constrictor, the middle constrictor muscle, the larynx proper, the cricopharyngeus, the thyroid, and this is the sagittal section showing all the constrictor muscles, the esophageal inlet, cervical esophagus, base of the tongue, supraglottic larynx, and the larynx. So delineation on every slice of the CT scan becomes important for us. Planning at NCI is done via a dose. Every patient is planned with a dose painting IMRT, whereby you can see this beautiful dose color distribution. Exactly the place where we want the radiation to go, that is the only place that is getting the radiation, saving the normal structures. Like here, the superior constrictor is being saved. Here, only the part of the base of tongue which is inside the target is getting the radiation. The rest of it is not. We are going one step further at NCI because dysphagia and aspiration-related morbidity and mortality is an important concern for us. We are trying to spare all the structures that are responsible for swallowing via meticulous planning. Here you can see the supraglottic larynx, the inferior constrictor, the cricopharyngeus and the larynx are being saved. This is the 95% of our dose, which you can see in color. Not only this, it is more important that we save these structures from the lower doses. Like this is the 50% dose color wash, that is 25 gray, which you can see is sparing the central organs at risk. And an even lower dose color wash of 15 gray, that is only 30% of our prescribed dose, that is also so beautifully sparing the larynx and the central ORs here. What was important is that we had a huge load of patients with only 2 functional machines, and it became important for us to explore other avenues. We explored hypofractionation in the intermediate risk group. We launched the HIPCON trial where we randomized those patients into the standard 60 gray in 30 fractions arm and the 50 gray in 20 fractions arm. And to the best of our knowledge, this was the first hypofractionation study in head neck cancers in the adjuvant setting. And the results have been encouraging. At 1 year, there is a 18.7% benefit in the locoregional control, which is statistically significant. 19.8% benefit in the disease-free survival, and probably the only hypofractionation study, to the best of our knowledge, of course, to show an overall survival benefit of around 6%. We were a little concerned about the toxicity outcomes, but both acute and late toxicities were comparable across both the arms. Inspired by the results of the HIPCON trial, we discussed this in a MDT, and we have started the HIPCON 2 trial, which is doing the same randomization with concurrent chemotherapy in the high-risk group, that is positive margins and extranodal extension. And we have already started recruitment of accrual of this trial. We are trying to reduce the morbidity and the toxicities of radiation. We have started the ELIMINATE trial after ethics clearance. It is a multi-centric trial which is evaluating whether we can totally omit neck radiation for N0 in neck, N1 neck in oral cavity cancers, and we have started accrual for the same. We are actively doing brachytherapy at our center. We have done 72 patients so far, 67% being in the radical setting. Like this is a T2N0CA tongue patient with the catheters. This was taken up in the radical setting, and this dose color distribution is so different from what we saw just earlier. This brachytherapy, this is the beauty of brachytherapy. It delivers dose only to the place where we want and not to any of the surrounding structures. Brachytherapy we've also taken up in the adjuvant setting. This was a T2N0CA buccal mucosa patient with positive margins, and brachytherapy was done for this patient. Outcomes of brachytherapy are also encouraging. For radical brachytherapy at 1 year and 2 years, our local control rates are 79 and 77%. For adjuvant setting, it is 75% and 72%. What becomes important is that we keep the patient disease-free and also provide the patient with a good quality of life and preserve his functional outcomes. We are trying newer modalities and finding newer, we are going beyond the routine indications. Like this was a CA floor of mouth patient, T2N0, post-surgery. He developed a massive recurrence in the floor of the mouth, going beneath the hyoid, and he had a draining sinus. He was declared unresectable. We delivered a 45 gray in 20 fractions with 4 cycles of concurrent chemotherapy to this primary with a margin and to the neck nodal levels, followed by a FBRT boost. That is a high dose boost, conformal, very, very conformal technique boost to this primary area. And at 3 months, the PET CT reports show a complete metabolic response in this patient. We are also trying dose escalation in the radical setting for patients who are being deemed unresectable to the advanced disease, like this is the T4A N2C CA tongue going into the base of tongue, 60-year-old female who was declared unresectable. We did a dose escalation. Normally, we prescribed 2 gray per fraction. We went up to 2.33 gray per fraction and delivered a total dose of 70 gray. And at 1 month follow-up, she had a 70% clinical response in the disease, and we are still awaiting the 3-month PET reports. So I would like to conclude by saying that collaboration actually paves the way forward, and we are thankful to all our fellow disciplines for supporting us throughout and helping us provide state-of-the-art care to our cancer patients. Thank you.
Good evening to one and all present here. I'm Dr. Sabita from the Department of Medical Oncology from NCI. I'm just going to give brief presentation on the institution protocol which we follow in NCI. Just all we know, the head and neck parts will be oral cavity, oropharynx, nasopharynx, and hypopharynx. So coming to the basic workup, just the differentiating points between oropharynx, oral cavity, and the nasopharynx. Apart from the basic CT, MRI, and examination under anesthesia with endoscopy. So specific for oropharynx, tumor human papilloma virus testing by P16 immunohistochemistry must required in oropharyngeal cancers, and oral cavity, the same which I mentioned here. And specific for nasopharynx, EBV DNA and EBER in situ hybridization. It's specific for each malignancies. And coming to directly to the treatment, in locally advanced head and neck squamous cell carcinoma, in resectable setting, surgical resection followed by adjuvant RT or CTRT. This is standard of care now, which we followed under in our institution. And coming to the indications for concurrent CTRT and RT, which previously our colleague mentioned in radiotherapy PPT, positive margin and extranodal extension for CTRT, and which we have our own institutional protocol, which was published as a concert trial, which was conducted in IRCH open label non-inferiority phase 3 randomized control study between weekly CDDP 40 mg per meter square versus 100 mg CDDP 3 weekly. In this, weekly CDDP is non-inferior to 3 weekly CDDP, which is better tolerated with less interruptions, hospitalizations, and toxicity, with good locoregional control and CR complete response rates. And coming to the borderline resectable and the neoadjuvant chemotherapy, actually it is a non-inferior to the standard of care. So we followed here is preferred regimen is TPF. TPF is docetaxel 75 mg per meter square and CDDP 75 mg per meter square and 5-fluorouracil 70 mg per meter square from day 1 to day 5. For the patients with good PS and for patients with poor PS, CDDP with docetaxel we are following. So, and also having our own TMH data here of TPF versus TP, followed by surgery 5-year overall survival. For surgery 50% versus 5%, and overall survival for 5-year 24% versus 18%. And just want to have a note on here actually HPV negative or more preponderance in our country, one point to note. And also even with the good standard of surgery with the treatment with the RT or CTRT, DFS is 50 to 60% in 3 years. And also the biological resistant disease. And also because of these tobacco chewing habits, which are more common in this oral cavity cancer, this issues to be sorted. And the future areas of research will be in neoadjuvant chemotherapy in localized oral cavity cancer does not improve survival. And few things to note is the toxicity of the TPF, 1 point, and with the major pathological response, which do extremely well in the long term with significant overall survival, which mentioned in studies such as TAX 3-4, TAX 3-3, and match NCI analysis, meta-analysis, and also have partial or stable disease to do poorly in the long term. So with this, we have the upcoming third process of having to get into a study with by the motto of decreasing the toxicity, modified TPF versus standard 3 weekly TPF with the endpoints which I mentioned here. and also the de-escalation of adjuvant therapy in the favorable pathological response to neoadjuvant chemotherapy in oral cavity cancer, and the escalation of adjuvant chemotherapy in unfavorable pathological response to neoadjuvant chemotherapy in oral cavity cancer, which the following study which I mentioned here, adjuvant methotrexate for 1 year versus adjuvant RT, and adjuvant RT plus methotrexate versus adjuvant RT with the endpoints. And for the locally advanced unresectable, standard of care definitive CTRT with CDDP 40 mg per meter square weekly. And coming to the metastatic setting, we following here is OMT plus nivolumab with OMT of methotrexate, celecoxib, and erlotinib with methotrexate 9 mg per meter square, celecoxib 100 mg per 100 mg BD, and erlotinib 150 mg OD with nivolumab 20 mg 3 weekly with a study of showing significant OS at 1 year more than 25% versus 16%. Because of the non-affordability and the pathological PDL1 status, because of the logistical constraints. So the standard therapy, which I mentioned here, Keynote 048, extreme trial, all those are we will not still follow. And our preferable treatment is here OMT plus nivolumab. This is data from the TMH, which we following the dose I mentioned here. Thank you.
Good afternoon, respected all. I'm Dr. Rachit Sood from the Department of ENT, and I'll be presenting a final note on our survival analysis of operated patients. We'll be looking firstly at as an overall cohort of oral cavity, then there's stage-wise distribution, there's subsite-wise distribution, and also we'll see the survival analysis on aggressive tumors of T4B and N3B stages. The survival outcomes are being measured as overall survival, which are from the date of surgery or last date of adjuvant till the date of death from any cause, and the disease-free survival is from the date of surgery or the last adjuvant till the date of recurrence. We have included the patients who have had a minimum follow-up duration of 18 months. Over the past 3 years, we have had a total of 444 patients of oral cavity, and these have been divided into subsite-wise into patients with gingival-buccal complex involvement. That forms the majority of our patients, that is 64%, and the remaining 36 are the tongue and floor of mouth patients. Stage-wise distribution, we have 76% of the total oral cavity patients who present to us in locally advanced stages, which are stage 3, stage 4A, and stage 4B. A brief note on the staging system. The T1, T2 tumors are classified as early stage tumors, and the T4A tumors are the ones involving skin or the bony involvement. And the T4B tumors are the tumors which are involving the masticator and infratemporal space, that is the masseter, the medial pterygoid, the lateral pterygoid, and the temporalis muscle. A brief note on the nodal staging system. Here we will be looking at a separate cohort of patients which are, since the presence of lymph node decreases the survival by 50%, and the presence of extranodal extension further halves the overall survival. So we'll be looking at a cohort of patients with N3B nodes. These are the nodes with extranodal extension. Here are the Kaplan-Meier curves of overall survival curve for oral cavity with a median survival of 43 months and a median follow-up of 20 months. Here we can see that the 3-year overall survival rate for oral cavity is 64%, and the below curve shows the disease-free survival for oral cavity, which is 52% for all subsites combined. On the right side here, we can see the overall survival curve stage-wise. The blue line represents stage 1, the light green stage 2, orange stage 3, dark green stage 4A, and pink stage 4B. And this graph represents the disease-free survival stage-wise of the oral cavity as a whole. As we can see that the overall survival drastically drops down from stage 1 being 94% to up to 42% in stage 4B. and the 3-year disease-free survival also halves from 72% to 36%. In the subsite-wise, the gingival-buccal complex, which forms the majority of our cases, here also a similar trend is seen, where the overall survival rate drops from 96% in stage 1 to 45% in stage B, and from 72% in stage 1 to up to 36% in stage 4B tumors. A similar curve is also seen for tongue and floor of mouth patients with a median follow-up of 21 months. Here we can see that the overall survival rate drops down from 88% to 38% in stage 4B, and from 88% disease-free survival to 34% in stage 4B as well. Coming to the two aggressive data sets of patients, that is clinically T4B subset. These are the patients who are, there is involvement of the infratemporal fossa and the masticator space. We have had a total of 23 patients who were operated out of 444 patients, and the mortality rate has been as high as 65%, demonstrating a significantly poorer overall survival and disease-free survival. Historically, all T4B tumors were considered unresectable, and the National Comprehensive Care Guidelines still advocates clinical trial and systemic therapy for these patients. These tumors are then further subdivided and compartmentalized into infranotch and supranotch tumors, as depicted in this figure. Here we can see an article published by Leah et al., which has compared the patients who have received neoadjuvant chemotherapy for supranotch and unresectable diseases, and they have shown a statistically significant better survival than the patients who have undergone non-surgical modality. So we do follow the protocol of infranotch disease just being upfront resectable, and it requires a radical compartmental resection with an infratemporal fossa clearance, whereas the supranotch diseases are given a trial of 2 to 3 cycles of neoadjuvant chemotherapy followed by response assessment. Looking at the comparing the overall survival rates of oral cavity as a whole and comparing it with the T4B tumors, we can see that the 3-year overall survival rate for oral cavity is 64%, which is been 56% for T4B tumors, and the 3 years disease-free survival rate is 52% and 54% for stage 4B tumors. Coming to the PN3B subset, the incidence of which has been 88 per 444 cases, that is 19.8% incidence. These are the cases which shows extranodal extension. The mortality rate has been 56% in these cases, showing a poor overall survival and poor disease-free survival. Pathologically, N3B has been a definitive indication for adjuvant chemoradiation. Here we are comparing the overall survival of oral cavity as a whole and comparing it with pathologically N3B nodes. The overall 3-year overall survival drops from 64% to 31%, and the 3-year disease-free survival drops from 52% to 26% in these cases. These are the mortality rates compared for various stages. Here we can see that the mortality rate is as low as 6 to 8% in stage 1 and stage 2 tumors, and as high as 33 to 50% in stage 4B tumors, and high mortality rates of 65% and 58% in aggressive subsets of T4B and N3B. We have also published our data of survival outcomes in the laryngoscope in the year 2021. In this article, we have seen the survival outcomes of 218 patients of oral squamous cell carcinoma who were operated between 2013 and 2016. And on comparing these with our recent data set of 444 patients, we have seen an increase in trend of presentation of locally advanced tumors from 65% of all to 76% of all oral cavity cancers. The gingival-buccal complex remains as the predominant subsite of presentation. On the overall survival, the median follow-up in that study has been 35 months and 25 months in our recent audit. The overall survival rate, 3-year survival rate was 67% and now is 64%. For early stage tumors, it was 86.7%, now being 90%, and marginally increased 3-year survival rate from 56.7% to 60% overall survival. Similarly, disease-free survival in the previous data set was 78.8%, now 72%, and 46.6% of 3 years disease-free survival to 50% of disease-free survival in advanced stages. Our future directions have been changing our practice from wide local excision to compartmental dissections, stratifying our aggressive subsets for an aggressive front, addressing the contralateral nodes and the upstream nodes of lingual lymph nodes and perimarginal nodes, targeting sentinel lymph nodes in early stage diseases, and also looking at the functional outcome apart from the oncological outcomes, assessing their speech, swallow, and back to normals.
If anyone has got any comments or any suggestion,
That is really good. That is not what one does. Anesthesia, pathology, therapy, having such dramatic new thoughts on how to treat these patients. They are well aware of what they have achieved, what to do. How equally does any other questions?
any other questions?
Now, okay, looks like the future is going to be much brighter than the past. So much of the publication coming from the NCI, so of course, we congratulations to the NCI, that include your colleagues, our colleagues, and
I asked the